Hello everyone! Today we will comprehensively cover nephrotic syndrome. We will discuss the definition, clinical features, classification, investigations, management, complications, and even compare it with acute glomerulonephritis. By the end, you will be exam ready. Definition of nephrotic syndrome. Nephrotic syndrome is defined by the tetrad of massive proteinuria, protein loss in urine of more than 40 milligrams per square meter per hour, or a urine protein to creatinine ratio greater than 2. Hypoalbuminemia, serum albumin less than 2.5 grams per deciliter. Generalized edema, swelling affecting multiple parts of the body. Hyperlipidemia, elevated levels of cholesterol and triglycerides in blood. Exam. Tip: this is the standard definition. Always quote the tetrad in examinations. Clinical features. Edema, hallmark feature, starts with periorbital puffiness in the morning, progresses to pedal edema, ascites, pleural effusion, and anasarca. Frothy urine due to proteinuria. Severe cases, breathing difficulty, or abdominal pain may be present. Note: edema alone is not diagnostic. Understanding proteinuria's cause is essential. Causes of proteinuria. Proteinuria occurs due to disruption of the glomerular filtration barrier, which consists of endothelium maintains charge selectivity. Glomerular basement membrane acts as a size and charge barrier. Podocytes with slit diaphragms, final filtration barrier. Damage to any of these structures allows albumin to escape into urine. Classification of nephrotic syndrome based on response to corticosteroids, most important in pediatrics. Steroid-sensitive nephrotic syndrome, SSNS. Complete remission within 4 weeks of daily prednisolone. Steroid-resistant nephrotic syndrome, SRNS. Failure to achieve remission after 4 weeks of daily prednisolone. Steroid-dependent nephrotic syndrome, SDNS. Relapse occurs while tapering steroids or within 14 days of discontinuation. Frequently relapsing nephrotic syndrome, FRNs. 2 or more relapses within 6 months of the initial episode or 4 or more relapses within 12 months. Reason: corticosteroid responsiveness determines prognosis and guides therapy. Based on etiology: primary, idiopathic nephrotic syndrome. No identifiable secondary cause. Examples: minimal change disease, focal segmental glomerulosclerosis, membranoproliferative glomerulonephritis. Secondary nephrotic syndrome, due to systemic or extrarenal diseases. Examples: systemic lupus, erythematosus, Henoch-Schönlein purpura, infections like hepatitis B, malaria, syphilis, drugs such as non-steroidal anti-inflammatory drugs, gold, penicillamine, metabolic disorders like diabetes mellitus, amyloidosis. Congenital nephrotic syndrome presents within the first 3 months of life, usually genetic, for example, Finnish type due to NPHS1 mutation. Reason: helps direct investigations and management. For example, lupus nephritis requires tailored immunosuppression. Based on histopathology, renal biopsy findings, minimal change disease, MCD. Most common in children, normal light microscopy, podocyte effacement on electron microscopy, focal segmental glomerulosclerosis, FSGS. Segmental sclerosis of some glomeruli, often steroid-resistant. Membranoproliferative glomerulonephritis, MPGN, thickened capillary walls with double contour. Membranous nephropathy, thickened glomerular basement membrane. Others: mesangial proliferative glomerulonephritis, diffuse mesangial sclerosis. Reason: histology guides prognosis and second-line therapy in steroid-resistant cases. Based on age of onset congenital nephrotic syndrome, within first 3 months of life. Infantile nephrotic syndrome, 3 months to 1 year of age. Childhood nephrotic syndrome, 1 year to 12 years of age. Adolescent and adult onset, after 12 years of age. Reason: age correlates with etiology and prognosis. For example, minimal change disease is common in 1 to 10 years, while FSGS is more common in older children and adults. Frequently relapsing and steroid-dependent nephrotic syndrome. Frequently relapsing. 2 or more relapses within 6 months of initial episode or 4 or more within 12 months. Steroid-dependent. Relapse occurs during tapering or within 14 days of stopping steroids. Exam tip: these definitions often appear as short notes. Laboratory investigations. Step 1. Confirm nephrotic syndrome. Urine routine and microscopy. Heavy proteinuria, usually more than 3+, bland sediment. Spot urine protein to creatinine ratio, more than 2, confirms nephrotic range. Serum albumin, less than 2.5 grams per deciliter. Serum cholesterol, elevated. Step 2. Baseline renal function. Blood urea, serum creatinine, electrolytes, usually normal in steroid-sensitive cases. serum total protein and immunoglobulins, reduced total protein and IgG, sometimes raised IgM. Coagulation profile shows hypercoagulable state. Step 3, rule out secondary causes. Complement levels, C3 and C4. Normal in minimal change disease, low in lupus nephritis or post-infectious glomerulonephritis. Autoimmune markers, ANA anti-dsDNA for suspected lupus. Viral markers, hepatitis B, hepatitis C, HIV. Step 4, renal biopsy, selected cases only. Indications, steroid resistance, age less than 1 year or more than 12 years. Gross hematuria, low complement levels, abnormal renal function at presentation. Findings, minimal change disease, focal segmental glomerulosclerosis, membranoproliferative glomerulonephritis, membranous nephropathy. Exam tip, follow logical flow, confirmation, baseline assessment, secondary causes, renal biopsy if indicated. Management goals. Achieve remission of proteinuria, prevent relapses, minimize drug toxicity, prevent complications. First episode treatment. Prednisolone, 2 mg per kilogram per day, maximum 60 mg, for 6 weeks daily, followed by 1.5 mg per kilogram on alternate days for 6 weeks. Supportive care, salt restriction, diuretics for edema, antibiotics for infections, vaccination updates. Steroid-sensitive nephrotic syndrome. Response rate, 80 to 90% in children. Prognosis, excellent normal renal function. Relapses, common but manageable. Steroid-resistant nephrotic syndrome definition, no remission after 4 weeks of daily prednisolone. Most common biopsy finding, focal segmental glomerulosclerosis. Treatment, calcineurin inhibitors, cyclosporine, tacrolimus, mycophenolate mofetil, cyclophosphamide. Prognosis, poor, risk of chronic kidney disease and end-stage renal disease. Steroid-dependent nephrotic syndrome definition, relapse during tapering or shortly after stopping steroids. Treatment, steroid-sparing agents like levamisole, cyclophosphamide, mycophenolate mofetil, calcineurin inhibitors. Goal, maintain remission with minimal steroid toxicity. Complications, infections mechanism, loss of immunoglobulins, complement proteins, and immunosuppressive therapy. Common infections, peritonitis, cellulitis, pneumonia, sepsis. Thromboembolic complications mechanism, loss of antithrombin 3, protein C, protein S, hyperfibrinogenemia, hemoconcentration. Events, renal vein thrombosis, deep vein thrombosis, pulmonary embolism, metabolic and fluid complications. Hypovolemia, plasma protein loss leads to intravascular depletion. Electrolyte disturbances, hyponatremia, hyperkalemia in renal dysfunction. Hyperlipidemia, hepatic compensation, chronic cardiovascular risk, other complications, growth retardation, osteoporosis, hypertension, anemia. Exam. Tip, mention mechanism plus clinical relevance. Differential diagnosis, acute glomerulonephritis, congenital nephrotic syndrome, secondary causes, lupus, infections, drugs, metabolic disorders, nephrotic syndrome versus acute glomerulonephritis. Nephrotic syndrome presents with generalized severe edema, often starting periorbitally and progressing to anasarca. Proteinuria is massive, serum albumin is low, and hyperlipidemia is a hallmark. Blood pressure is usually normal or low, and complement levels are typically normal. Hematuria is generally absent. In contrast, acute glomerulonephritis usually presents with mild to moderate edema, often periorbital. Proteinuria is mild to moderate, hematuria is often gross, and serum albumin is usually normal or only mildly reduced. Blood pressure is elevated and complement levels, especially C3, are low in post-infectious cases. Lipid levels remain normal. Key point, nephrotic syndrome emphasizes protein loss and hypoalbuminemia. Acute glomerulonephritis emphasizes hematuria, hypertension, and complement changes. Conclusion, nephrotic syndrome is proteinuria, hypoalbuminemia, edema, and hyperlipidemia. Always classify based on steroid response, cause, histopathology, and age. Investigate systematically, manage with steroids and steroid-sparing agents, and focus on preventing complications and long-term renal damage. Exam question to ponder. In a child with steroid-resistant nephrotic syndrome and normal complement levels, which histopathology is most commonly seen? Answer in the comment section.